So the APOLLO trial was a prospective randomized phase 3 study investigating ATRA plus arsenic trioxide supplemented with 2 shots of idarubicin during the induction therapy with the standard ATRA chemotherapy, or so-called AIDA backbone in patients with high-risk APL. The latter was defined as more than 10,000 leukocytes per microliter at study entry, and patients could be included up to the age of 65 years. I think the uniqueness of the trial was for the first time to compare an almost chemotherapy-free regimen in high-risk APL patients to the standard chemotherapy ATRA backbone in high-risk APL patients. This was a multinational European trial in 6 European countries. All main study groups in the European Union have been involved at 143 study sites. The primary endpoint of the trial was the 2-year event-free survival. Initially, 280 patients were aimed to be included during the study period. Unfortunately, the study had to be stopped prematurely, and only a little bit more than 130 patients could be included. This was mainly due to reasons of study delay during the COVID pandemic. The good news is that the primary endpoint was met with a 2-year event-free survival favoring the experimental arm. Actually, this is very important, and this was not achieved at the expense of more toxicity. In contrast, early death rates were the same between both arms. CR/CRI rate was exceeding 90% in both arms. The main difference was the rate of molecular resistance, which was basically almost absent in the experimental arm, and the rate of relapse, which was significantly higher in the conventional chemotherapy-based arm. Also important to state that neutropenia and thrombocytopenia grade 3, grade 4 occurred only in roughly 1/3 of the patients during the induction course, and was basically absent during the consolidation. So to summarize, we believe that the APOLLO trial, although only first results have been reported at the EHA meeting, set a new standard of care, a new treatment paradigm in patients with high-risk APL. And at least I can speak for our center here, and I think also for all the centers I've been talking to. We will change this treatment paradigm in the near future for all patients presenting with high-risk APL at our site.